Sathyabama Institute of Science and Technology.
Good morning all. I'm Dr. Deepa, Assistant Professor, College of Physiotherapy, Sathyabama Institute of Science and Technology, Deems to be University. Today my session is about proprioceptive neuromuscular facilitation. I have divided the session into part 1 and part 2. Let us check out with part 1. The learning objectives. The learning objectives are, we will be defining the proprioceptive neuromuscular facilitation. Throughout the session, I'll be using it as PNF. Next, we'll discuss the treatment of physiology under the framework of PNF techniques. Further, we'll discuss the diagonal patterns which are available for its applications. Definition. Proprioception means receiving stimulation. Further, neuromuscular pertaining to nerves and muscles. Later, facilitation, it means its effects on the motor response. Introduction. Introducing proprioceptive neuromuscular facilitation, it's an approach, it's a therapeutic approach, which is a combination of diagonal patterns and PNF techniques to evoke motor performance and also the neuromuscular efficiency. Further, we'll look into the neurophysiology of PNF. I'll be briefly discussing about the muscle spindle, Golgi tendon organs, the afferent and efferent pathways, myostatic stretch reflex, facilitation and inhibition, reciprocal inhibition and autogenic inhibition. First of all, let us see the muscle spindle. The muscle spindle has intrafusal fibers and extrafusal fibers. The fibers have a capsule, intrafusal fibers, stretch receptors. These are the stretch receptors, these are the intrafusal fibers, and these are the afferent nerves. The extrafusal fibers, they taper down to connect with the bone at a junction of tendon. These tendons have the Golgi tendon organs. They are the mechanoreceptors for the tendons. Let us look into the myostatic stretch reflex. This is a circuit diagram of the myostatic stretch reflex. Let us take an example of a knee jerk. The knee, when it's been strung by a knee hammer, the sensory receptor organs, through the sensory afferent fibers, it enters through the dorsal root ganglion on the posterior aspect of the spinal cord, thus having an integration at the center of the spinal cord, further exciting out from the motor neurons from the anterior horn cells. They have two pathways. One is the inhibitory pathway and one is the excitatory pathway. The darker red line, which is the excitatory neurons, they will exit out, further agonist contract, antagonist contracts. The effector organs relieves tension due to the inhibition of the neurons. After looking into the myostatic stretch reflex, let us look into the reciprocal inhibition. When one muscle is contracted, its antagonist is automatically inhibited. That's the circuit diagram for the inhibition and the working of the balance agonist and the antagonist. Autogenic inhibition. When a muscle is put to stretch for a prolonged period of time, it contracts isometrically. The Golgi tendon organs are activated and inhibits the tension, allowing the muscle to contract. During this elongation or an extreme tension, it helps prevent the possible tearing of tendon. This process is called as the autogenic inhibition. Now let us look into the principles of PNF. Human potential are not fully developed. The motor behavior, it's looking into the cervical caudal direction and proximal distal directions. Reflex activity dominates in the early stages of a life of a newborn. Whereas as the maturation of the motor behavior happens, the postural reflexes sets in. Motor growth is a cyclic trend between the agonist and the antagonist, the flexors and the extensors. Normal movement and posture depends upon the synergism and balanced interaction of antagonist. Frequency of stimulation and repetitive activity promote motor learning and muscle development, strength and endurance and muscle memory too. Now let us look into the movement patterns. There are two components in the movement pattern, that is the angular pattern, which is a rotatory component, and the another one is the distal, which follows the proximal pattern. Let us look into the diagonal patterns for upper extremity. Here are some figures which shows the diagonal patterns. The first picture, the D1 flexion, it shows the shoulder flexion, adduction and external rotation. When we go to the D1 extension, it is extension, abduction and internal rotation. Here I have used some abbreviation for easy understanding. The D2 diagonal flexion abduction and extension, external rotation. Further, D2 extension is extension, adduction and internal rotation. Now, let us look into the diagonal patterns of lower extremity. These are the diagonal patterns of lower extremity. The upper two pictures, the left side corner shows the D1 movement pattern starting position to the D1 movement pattern ending position. Starting position is extension, abduction and internal rotation, while the ending position is flexion, adduction and external rotation. The lower two pictures are again D1, starting position, flexion, adduction, external rotation and ending at the extension, abduction and internal rotation. Let us look at D2 pattern. D2 pattern of lower extremity, this is the starting position where the hip joint is at extension, adduction and external rotation. Terminal position is flexion, abduction and internal rotation. Let us look into D2 pattern, which is flowing from flexion, abduction, internal rotation to hip joint position of extension, abduction and external rotation. Now let us look into the diagonal patterns of upper trunk. The upper trunk, as you can see, the first two pictures, it's like a chopping movement, a wood chopping movement. There's a spiral and a diagonal position. The lower two positions are the lifting of objects from the floor. Let us go into the diagonal patterns of lower trunk. The lower trunk also provides a pattern from starting position into a flexed position having a rotational component to that at the pelvis. The lower trunk pattern, which goes into the extension position from a flexed position, the patient also guides the movement along with the manual contact. Now, the application for diagonal movements, where and all these diagonal movements are helpful. Gait, balance, stability of the gait, improving the upper and lower extremity coordination, enhancing the gait stability, improving the balance of the patients, improving the patient's ability for ADL activities, and then providing an independence in his daily living activities. Thank you.